Hi, my name's Daniel Jolly. I'm an anaesthetist or anesthesiologist from Melbourne, Australia, and today I want to talk about anaesthesia in pregnancy for non-obstetric surgery. Now, this is a common situation. Something like 0.75 to 2% of all pregnancies will require a surgical procedure during their pregnancy. In the US, that makes around about 75,000 pregnant women undergoing non-obstetric surgery every year. Now, what's interesting is this probably grossly underestimates the number of pregnant women that have or require surgery during their pregnancy. Because we know that about 1 in 300 female outpatients is actually unknowingly pregnant, and something like 1 in 80 adolescents are unexpectedly pregnant. So there are probably far more women during their first trimester that are receiving an anaesthesia for surgery, and we don't even know that they're pregnant at the time. Now, the indications for surgery during pregnancy, although they're quite wide and varied, there are 3 main surgical pathologies that require anaesthesia and surgery. Firstly, something like 42% of women actually have surgery for an adnexal mass, that is, a mass or a cyst on the ovary. 21% of surgeries during pregnancy are made up of appendicitis, which probably occurs in about 1 in 2,000 pregnancies. Biliary problems, gallbladder problems, 2 to 5 per 10,000, making up about 17%, and the remainder 21% of cases due to trauma surgery, breast surgery, bowel or cancer-related surgery. Now, the timing of the surgery, overwhelmingly 42%, so almost half of all surgeries during pregnancy occur during the first trimester. Now, this is probably largely because a lot of these are occurring at a time when people don't realise they're pregnant, or it's at a stage where there's a surgical pathology that's decided that this is the most appropriate time for things to be intervened. 35% occur during the second trimester and 23% during the third trimester. This was taken from a study in 2007 by Van der Velde. We was looking at the range of anaesthesia for non-obstetric surgeries. Now, if we start with appendicitis, which is the most common single pathology requiring surgery during pregnancy, this occurs in about 1 in 2,000 up to maybe 1 in 6,000 pregnancies, depending on which case series we look at. So it has an incidence of about 0.05%. Now, most appendicitis or most appendicectomies occur during the second trimester. We look again here at 2 case series from 2 different institutions, although there's still quite a lot of surgery occurring in the first and third trimester. Now, the difficulty with appendicitis is that it's quite challenging to diagnose during pregnancy. The symptoms can be very non-specific. There tends to be a diagnostic fixation area where if you're pregnant and you've got abdominal pain, there's a tendency to assume that all pain and problems are associated with the pregnancy itself rather than unrelated pathology. And finally, the presence of the gravid uterus tends to push the location of the appendix higher and higher in the abdomen. So Baer in 1932 identified a changing position of the appendix during different stages of the pregnancy, noting in the first, second and third trimester that the appendix was pushed further and further until that, in the third trimester you could actually present with right upper quadrant pain because of the size of the pregnant uterus now taking up all of the abdominal cavity. The symptoms range also make it very difficult to diagnose appendicitis during pregnancy. So the typical or classical symptoms of acute appendicitis, abdominal tenderness, nausea, vomiting, anorexia, unfortunately are almost exactly the same as symptoms that occur during normal pregnancy. Abdominal tenderness, nausea, vomiting, anorexia. So it can make it very difficult to discern for an individual patient whether this is a normal or typical situation or whether this is something abnormal and new. The symptoms that appear during pregnant-associated appendicitis are also a little bit different from that occurs in the non-pregnant person. So, although abdominal tenderness is almost universal, rebound tenderness, although very common, is not universal. And finally, anorexia, which is almost universal in appendicitis in those who are not pregnant, occurs in only 30 to 60% of those who are. And this is a very important consideration if we're seeing people in the emergency department or the ER with abdominal pain who are pregnant, and we're concerned that this might be appendicitis. The other controversy is whether these are best dealt with laparoscopic or open surgery. One study looking over a 7-year period, now these are all retrospective studies, so we don't have any randomized studies, so we need to take the results here with a grain of salt. Demonstrated that there might be a higher rate of fetal loss in the laparoscopic group, which comprised, so a loss of about 6% compared with the open group. The fetal loss was unsurprisingly much greater if it was complicated appendicitis. However, the preterm delivery rate was actually lower than the laparoscopic group. Now, the complications associated with laparoscopic surgery in this particular cohort study were the same even if there was a negative appendicitis, so even if the appendix was normal, which occurred in up to 30% of patients, demonstrating the difficulty with the diagnosis. Other studies, though, bring in certain questions about whether we can apply this sort of association of a higher rate of fetal loss in laparoscopy. So, since that time, we've seen studies that have demonstrated that laparoscopy with considerations is a safe approach to appendicitis during pregnancy, and also case series demonstrating safety of laparoscopy for appendicitis. Finally, one of the largest studies looking at pregnancy and laparoscopy or open surgery that was produced came out of the Swedish Health Registry, but produced out of Stanford. And they investigated 2 million women, so collecting 2,000 laparotomies and over 1,500 laparoscopies, and they found that there was no difference in fetal outcome for that period, no increased rate of malformations, and that cumulative 1-year survivals for fetuses and babies was exactly the same, regardless of whether laparoscopy or laparotomy. So that gives us a certain degree of reassurance that the laparoscopic approach to appendicectomy is probably safe. Now, cholecystitis and cholelithiasis is also a common surgical problem during pregnancy. Pregnancy is associated with increased risk of gallstone formation. That's due to both increased biliary sludge in pregnancy, increased bile viscosity, and also an increased tendency to produce micelles, and a gallbladder relaxation due to progesterone. And we see cholecystitis and cholelithiasis in 2 to 5 per 10,000 pregnancies requiring surgery. Cholecystectomy, there's good evidence for much better outcomes with a surgical intervention in cholecystitis versus a conservative management when it occurs during pregnancy. Unlike appendicectomy, laparoscopic approach for cholecystectomy is largely considered safe during pregnancy with certain caveats. The surgeon needs to aim for a low pneumoperitoneum with pressures ranging from 8 to 12, but certainly no higher than 15 millimeters of mercury. We know from sheep studies, so in ewes who are pregnant, that an intraperitoneal pressure of 20 millimeters of mercury is associated with a 60% decrease in uterine blood flow, although this doesn't have any fetal consequences in that model. But so it's important for us to press on our surgeons the need to aim for a maximal intraperitoneal pressures of only 15 millimeters of mercury. And management of hypercapnia is the same as for non-pregnancy, other than we have to make sure we have a lower target, considering that the pregnant woman has a lower set level of arterial CO2. Now, we have seen, however, an increased incidence of low birth weight in patients having a cholecystectomy, although it's difficult to separate out the underlying pathology as a cause from the actual surgical or anaesthetic intervention. This graph quite nicely shows the increasing peak inspiratory pressures with increasing gestation for laparoscopic cholecystectomy. It's not a perfect correlation, but we can see with increasing gestational age and so forth, increasing size of the gravid uterus, we see an increase in peak inspiratory pressures during ventilation. Now, the risks of surgery in pregnancy, really we can break that down into risk to the mother and risk to the fetus. Now, the risk to the mother, beyond the risks normally associated with any anaesthetic or surgical intervention, really come down to airway, and the increased risk of difficult or even failure to intubate in a pregnant patient. And we always need to bear that in mind whenever we approach any pregnant patient requiring anaesthesia. Now, the risk to the fetus, there have been concerns historically about the teratogenicity of anaesthetic drugs. Now, largely most of that has been demonstrated not to be the case. Nitrous oxide is now considered to be safe during pregnancy if that was part of your normal anaesthetic techniques. There's obviously an increased rate of miscarriage and premature delivery, an increased rate of low birth weight. Again, though, very difficult to separate this out from the cause of the consequences of the underlying pathology versus the surgical or anaesthetic intervention. There's obviously a direct risk to the fetus of uteroplacental circulation changes from the anaesthetic and surgical intervention, but we need to balance all this up against the risk of the pathology continuing in the pregnancy, and largely the risk of the pathology continuing will be far greater than the small risk of intervening from a surgical anaesthetic point of view. Now, Mars and Carlin, again out of Stanford, looking at the Swedish Health Registry, they performed one of the largest reviews of pregnant women undergoing surgery over about a 17-18 year period. And they looked at about 5,500 women, and they found that there was even at this stage in the 70s and 80s, there's still a good proportion of women undergoing laparoscopic surgery. And they demonstrated that there was an increased risk of fetal death at 7 days. There was an increased risk of low birth weight, but there was no increased risk of congenital malformation or stillbirth. And this is very important. It's unsurprising that there's increased rate of low birth weight, given that there's underlying pathology. It's disappointing, but not surprising that there's increased rate of fetal death. But it's quite reassuring to see that there's no increased rate of stillbirths and there's no increased rate of fetal anomalies. Basically, there was a 22% rate of premature delivery in the first week after surgery. And it's very important for us to remind our surgeons and to inform patients that there is this risk associated with their surgery and their anaesthesia. But if pregnancy continued beyond a week after surgery, there was no further increase in preterm birth. Now, the second trimester procedures and those that do not involve direct uterine manipulation carried the lowest risk of preterm labour. So obviously, if we have a choice, we want to time our anaesthesia and surgery during the second trimester. And there was no evidence at all that any particular anaesthetic technique or agent influenced the risk of preterm labour. Now, it's very important for us to understand and consider the placental physiology and how our anaesthetic affects that when we're approaching anaesthesia in the pregnant patient. Firstly, we need to consider whether there's a risk from hyperoxia. Obviously, we want to avoid hypoxia because that's going to affect fetal oxygenation, but there is also some concern that hyperoxia, so a high level of inspired oxygen, will affect the fetal well-being by increasing free oxygen radicals. So in an ideal situation, it's probably best to approach this with providing the minimum safe level of oxygen. And we need to consider the carbon dioxide and acid-base effects. And we know that hypercapnia in the mother, so if we allow the mother's carbon dioxide, arterial carbon dioxide levels to rise, that's going to have effect on the fetus and lead to a respiratory acidosis in the fetus. But we also need to consider that if we push the carbon dioxide too low, that hypocarbia will potentially lead to uterine artery vasoconstriction and therefore worsen uteroplacental blood flow. So again, we want to maintain carbon dioxide within normal ranges for the pregnant patient. And finally, we need to consider uteroplacental perfusion and how it's affected by maternal systemic blood pressures. Unsurprisingly, we have primate studies suggesting or demonstrating that hypotension is bad from uterine placental perfusion. So we know that the uteroplacental perfusion is not autoregulated. So the spiral arteries are maximally dilated at a normal blood pressure. So ideally, we'd aim for a mean arterial pressure in the mother of about 65 millimeters of mercury. Although reassuringly, there are anecdotal human reports of systolic blood pressures of 70 or 80 being tolerated without any fetal effects. Nonetheless, oxygen, carbon dioxide, blood pressure, as with all anaesthetic approaches, we want to maintain as closely as possible a homeostatic sort of system. So how are we going to put all of this information together to provide clear guidelines for approaching anaesthesia and surgery in the pregnant woman? Firstly, we need to consider the timing of the surgery. So first, elective surgery should not be performed during pregnancy if at all avoidable. So only surgery that really must happen and cannot be delayed without putting the mother or baby's health at risk. We need to avoid surgery during organogenesis during the first trimester, if at all possible. The second trimester is the most optimal for surgery, balancing the potential risk for the fetus during organogenesis with the more extreme physiological changes during the third trimester of the mother. So that allows us to maintain the safety balance for both mother and fetus most ideally. Now, surgical management is generally the same as for non-pregnant patients, so we don't need to consider necessarily that there are special surgical interventions required. And fetal well-being is largely dependent on maternal well-being. So what's good for mother is good for baby, and we need to very much focus on the safety of the mother in these scenarios. Now, from an anaesthetic point of view, there's no demonstrated advantage of regional over general anaesthesia. There are some suggestions of benefits or detriments of particular techniques in some case series, but overwhelmingly, there's no consistent guidelines here. So we need to assess this on a case-by-case scenario and generally choose our anaesthetic technique based on the needs of the particular patient. So the considerations are the same for any pregnant anaesthetic. We need to be very mindful of the risk of difficult airway. We need to consider the risk of aspiration. So after 18 to 20 weeks, we should consider rapid sequence induction. And we also need to not forget the presence of aortic cable compression also at about 18 to 20 weeks. Finally, we need to be mindful of the normal pregnant PaCO2 being lower in pregnancy than it is in mother. So if we were to maintain a normal non-pregnant CO2 during our anaesthetic, then we risk actually a relative hypercapnia in the pregnant patient. Now, fetal monitoring is often something that comes up Ideally, we should really monitor the fetal heart and uterine tone both before and after the surgery. Now that's usually relatively easy to do. If we get a midwife or an obstetrician, we'll send the patient quickly down to the labour ward to be monitored. The difficulty comes when we need to consider intraoperative monitoring. Now, for most types of surgery, this is usually impractical, particularly if this is abdominal surgery. It also requires the continuous presence of someone who's able to interpret the fetal heart rate. Now, fetal heart rate variability is something that we use as an indication of fetal well-being. It represents the functioning of the sympathetic nervous system and therefore is representative of underlying fetal stress and cardiovascular function. Now, it's usually present for about 25 to 27 weeks, and that variability representing normal function. But anesthesia will both depress the absolute level of fetal heart rate and also reduce the variability, so it can be very difficult to assess what is normal intraoperatively in a patient undergoing an anaesthetic. Nonetheless, it's important for us to consider both monitoring and documentation both before surgery and anaesthesia and after of the presence and health of the fetal heart rate. If you want to learn more about this topic, there's a very useful and in-depth review article from Reitman and Flood from the BJA back in 2011 that's worth reading. And it goes into a little bit more detail and some of the other studies associated around the anaesthetic considerations for non-obstetric surgery during pregnancy. Thanks very much.